So today I'm really excited to have one of the people I think is one of our greatest minds in population mental health, um, Dr. Sandro Galea, who is the Dean and Robert A. Knox Professor at the BU School of Public Health, and also a longtime collaborator and friend. So we're really honored to have him here today. And I really encourage folks, I'm going to embarrass him a little bit, to go to his website, which is sandrogalea.com, and look at his newsletter, The Healthiest Goldfish. And he is one of the foremost communicators of the public in the importance of population mental health and related issues. And so I encourage everyone to go there and sign up for his various talks and his newsletter as well. So welcome, Sandro. Thank you for doing this.
Well, thank you, Dr. Cohen. Thank you, Kath. It's really a privilege to be here to join you all. It's really a privilege to be among old friends. So let me share my screen. And can you see that okay? Very good, excellent. So, I really was I was asked to do a sort of big picture talk about trauma, traumatic stressors, both economic and social, and population mental health. And what I want to do is, as I'm going to show you in a second, I'm going to draw heavily on conceptual work that I have done with my good colleagues, Dr. Carrie Keyes, who's at Columbia, about how we think about population health broadly, and apply it to a framework of population mental health, and in particular around economic social stressors. So my goal really is not just to give you sort of data from various studies, but to try to give a framework for how to think about economic social stressors and population mental health. So let me start with just some fundamentals about traumatic stress signs. And I do want to start really with basics and talk a little bit about what do we mean by traumatic event. This is a definition of traumatic event. There are many such ones, but I think this applies very well, which is fundamentally, it's an event that causes physical, emotional distress or harm, threatens our safety and stability of our world. Now, when you think about that, I really think that this definition is important because it helps you realize that a moment like the one we're living through, a moment like the one where we have all been worried about COVID and the world around us, the economic pressures that we've been facing in the world, and the civil unrest coming from the legitimate anger about decades and centuries of marginalization of particular groups. These are all traumatic events that we are actually living through together. So I think we are living in a moment of multiple traumas, which ultimately has real impact on population mental health, as we are seeing study after study emerging. This is one very simple data slide. All I want to show in this paper is this dose-response relationship between number of lifetime traumatic events on the x-axis and likelihood of past-month depression. And this is, I'm taking just one slide from one study just to make the point that fundamentally, to my mind, the literature is pretty unequivocal that the more traumatic events one experiences, the more stressors one experiences, the worse it is for one's mental health. Now, there is a literature, I realize that, about things like growth and the potential for sort of emergence of people with some positive traits in the context of trauma. But fundamentally, from a population mental health point of view, traumas and stressors result in a negative consequence for mental health, which I think puts a real onus and responsibility on any of us interested in public health and in public mental health to think about ways to mitigate traumas and stressors. Now, traumas then sort of fold up into larger scale events, which we typically call disasters. So disasters are potentially traumatic events that are collectively experienced. They can be attributed to anything, natural, technological, or human causes. But they're fundamentally traumatic events taken up to any sort of larger scale, which is really the moment we're experiencing. We're experiencing traumatic event experience as a disaster in the context of COVID, I would argue, in the context of civil unrest, I would argue, in the context of economic stressors. A number of disasters worldwide, excuse me, has been increasing. As you can see here, this is from the relevant WHO database showing number of disasters increasing, which means there are more and more populations experiencing traumatic events. Now, why are disasters increasing? They're increasing for two reasons, really. Number one is global environmental climate change, which has resulted in more sort of weather-related traumatic events, and also because we're having more people live in cities. So cities are typically near water, and they're exposed to natural disasters. So it means there are more and more people in the population exposed to these large-scale traumatic events. And just to give you a sense of the scale of these large-scale traumatic events, now, I sort of used the slide before COVID. In the context of COVID, you're like, well, we're talking about the whole country exposed to a traumatic event, which I think is true. But just to give you a sense of a sort of, perhaps to ground it a little bit more practicable, this is after Hurricane Katrina in New Orleans. The orange areas were areas that were declared disaster areas. And the Hurricane Katrina, which was a big event, yes. And we talk about Mississippi and Louisiana, yes, we understand, but I think sometimes we don't wrap our brain around the fact that the areas of Mississippi and Louisiana that were declared disaster areas were equivalent in size to the entire United Kingdom, just to give a sense of how large scale these events are. And even I think in the moment, although I suspect most people on this call would probably resonate with and understand me saying, look, we're living through a collective national trauma that's affecting the whole country. It's hard to wrap our brain around the fact that that means hundreds of millions of people are exposed to traumatic events, which by definition are events that threaten our sense of safety, threaten our physical and our mental health, which is exactly the moment that we're going through right now. The general pattern of the consequences of these events are that you have greater density of poor mental health closer to traumatic event, and it dissipates as you get further away from traumatic event. This is illustrated, I think, in this study, in this graph from research that our group had done after 9/11. And what you see here is Manhattan in the middle and New York. And you see darker colors in the middle, which is closer to World Trade Center, and the colors get lighter as you go out, this prevalence of post-traumatic stress disorder, which is very typical pattern for disasters and large-scale traumatic events that we had seen in the past, where you get closer to disaster, you have more poor mental health, and you get further away, your mental health gets better and better. This, of course, changes in conception once you start thinking about things like COVID or large-scale economic stressors that affect whole populations, where there's no clearly an epicenter. There's no clear epicenter where you have events that are affecting whole populations. And one last note about sort of general disasters before I get into the meat of my talk is that what we do know about these disasters and the large-scale traumatic events is that they linger for a long time, and part of what matters is not simply what happens in the short term, but also what happens in the long term. This is from a study that was done in the Netherlands, one of the best studies to show this, although it was a relatively small study. And this was after an explosion in the Netherlands. And because of all people in the community being on electronic medical records early on, it's about 20 years ago, they're able to show what people were like, what their health was like before the event and after the event. And all I want to show you here is, you see, sort of health goes on, bad thing happened, health gets worse, and then things go back to baseline, but they don't really go back to baseline. You see how they actually stay higher than baseline, particularly among people who are really affected, those who are here relocated after this explosion. So the effects of these events linger for a long time. And it is that combination, the combination of the fact that we currently have a situation where we have a large-scale economic social stressor with no epicenter, which means no geographic dissipation, with the anticipation that the consequences will go on for a long time, that I think concerns any of us who are concerned with population mental health about now and going into the future. So now, having given that framework, giving the framework of what a traumatic event is and what a mass traumatic event is, I think it's important to sort of say, how do we think about individuals and how do we think about populations? And what does it mean to think about populations, and what does it mean to think about population mental health? So just schematically, if one were to think about a group of persons, created here in gray, an individual-based approach or patient-based approach looks at people in the corner. These are people perhaps with a particular disorder, people in who we diagnose who are in the corner. That could be one approach, but a population mental health approach says we look at people who have poor mental health in the whole population. And we want to think of a way to actually tackle that by lowering the burden of poor mental health in the whole population. That approach necessitates that we look at whole populations and necessitates that we take a lens at the fullness of the economic, social stressors that ultimately are precipitating the poor mental health. So what happens when we think of individuals only, when we don't think of whole populations? Well, what happens is this. This is the increase in antidepressants in the United States over the past couple of decades, showing more and more increase in antidepressants. And there's another set of graphs showing increase in ADHD medication, anxiolytics, antidepressants, and psychotic mood stabilizers. That when we focus only on individuals, we ultimately intervene in the way we know how to intervene with individuals, which is actually we provide pharmacological treatment for individuals, because that's what happens when we focus only on individuals, when we're not looking at whole populations and saying, how can we mitigate poor mental health by thinking about whole populations. And in some respects, what we're doing is we're doing something like this. This is from a famous soccer player. His name is Mario Balotelli. He used to play for a team called Man City. It's a good soccer team. And he scored a lot of goals with Man City, and his ego was very robust. And he would score a goal, pull up his shirt and show the thing saying, "Why always me?" He's an excellent player. And then he left Man City, and then he stopped scoring goals. And the moral of the story is that, he's scoring goals. He's a good player, but ultimately he's a good player playing for a very good team who's passing him the ball. When he left Man City, he actually had much less assists. And as a result, he didn't do anywhere near as well. That is always the tension between the individual and population. We tend to focus only on the individual and we say it's individual is causing things and the individual we should focus on, but we keep forgetting that the individual fundamentally is part of population. And as we think about mental health, if our intent is to create a healthier population and create better population mental health, we need to think of whole populations, think of the whole thing. So with that said, can thinking about populations help? So the answer is yes. I think thinking about population can help. I think thinking about populations is inevitable. And what I want to talk about is a set of few principles about how we may think about population. So these are principles that emerge, as I said, from work I've done with Dr. Catherine Keyes around population health science applied to population mental health thinking. And I want to show you what some of these principles are by way of illustrating why thinking about populations may help illuminate how we can better understand mental health to the end of improving population mental health. So the first principle, the causal population health are multi-level and accumulate over the life course and across generations. To really think about population mental health, we actually need to think about multiple levels and people's whole lives. The way to think about this is like this. This is from a schematic from Dr. George Kaplan, where it says health fundamentally is pathophysiologic and genetic. Sure, that's what gets under my skin. But that what gets under my skin is influenced by my risk factors, sure, whether I smoke, whether I drink, what my social relationships are like. But that, of course, influenced by my living conditions, the neighborhoods where I live, the institution in which I live, and our social economic policies. That says that our full set of influences on our health is a full set of nested circumstances. It's a full set of nested circumstances without which we cannot understand how health manifests in me. And when you see that, you realize that it's actually quite difficult to understand my health simply by understanding my genes alone, for example, or my pathophysiology alone. Just like it's hard to understand my health just by understanding the social policies within which I live. Fundamentally, health is a sum of all of those. And it's a sum of all of those over the life course. So this is a modified diagram about development of health over the life course, and what you see is over age in the x-axis. Genes matter, and they matter more or less consistently over our life. But what really shapes our health is the accumulated risk from a life course experience. In prenatal, our mother's safety, our mother's nutrition. Infancy, whether we're exposed to violence, whether our parents separate, our access to food and education. In adolescence, our social support, discrimination, family behavior, employment conditions in adulthood, our social isolation in older age. And all of that accumulates risk, and accumulates risk over the levels that I showed you before. So mental health fundamentally is a product of multiple levels of influence and experienced over the life course. And it is, as I'm going to show you in some of the other principles I'm going to get to in a second, it is impossible to understand mental health fully without understanding both of these determinants. Just to give you an example of that, I want to show you this from a study which we had done about 10 years ago, where we actually were looking at mental health in Liberia. This is in northeastern Liberia. It's a country in West Africa, which had sort of quite, unfortunately, well, famous for civil war. And Liberia had a civil war started in 1990. And this is a province called Nimba in northeast Liberia. And this is where the civil war started. And actually what you see on the right is Cote d'Ivoire, which is a country where rebel army came in. And the rebel army, what these circles are with numbers, are skirmishes between rebel army as they moved through Nimba all the way to Monrovia, the capital of Liberia. So that's where the battles were. We did a study 20 years later. And 20 years later, we mapped out the burden of PTSD in the community. And the bigger circles, the darker circles are where there was more PTSD. And what you see, which is pretty remarkable, is burden of PTSD mapping exactly where the battles were 20 years before. Now the wars had long ended 20 years before. But you see this long tail consequences of the war that is imprinted on the local community. And these were people, we studied people 18 years and older, which means we had people who weren't even born when the skirmishes passed through. But the reason is that these skirmishes resulted in a shift of the social and economic circumstance that then affected people's lives in multiple ways and affected PTSD in many other ways. Because if you now have more unstable economies, less economic opportunity, more violence, that's going to result in more downstream manifestations of post-traumatic stress, which result in the picture you see in Liberia many decades later. And I think that is true now, as it is true always, which it makes it very difficult to think about population mental health without recognizing its life course impact and its life course impact over the multiple levels of context that shape our lives. So that's point A. Point B, population health, and here I'm focusing on population mental health, of course, is multidimensional. Now there's a long debate in psychiatry and psychology about dimensionality versus categorical thinking about mental health, and that's fine. But I'm talking less here about the correctness of reporting our data or the correctness of how we think about it in the clinical world, and more about the fact that unless we think about the dimensionality of mental health, we actually miss a substantial portion of the population burden. So I'll illustrate that first by starting with physical health, just because sometimes it's easier. So this is body mass index, and we talk a lot about the overweight and obesity epidemic in the country, and we do that by doing a cutoff, right? Body mass index of 30, say higher than its obesity. That, of course, misses the entire population distribution of what population BMI is under that. Now, why does that matter? Well, let's look at this slide. This slide looks at the general population. It's the data from NHANES, which is National Health and Nutrition Examination Survey, national study. And you see the cutoff of 30 with obesity. And what you see is the curve in NHANES in 40 years ago and the curve 10 years ago. And what you see is that the curve has shifted to the right. That yes, the dotted line, you see the area under the dotted line is much higher 10 years ago than it was 40 years ago, which means greater prevalence of obesity, yes. But look at on the left. On the left, you can see that the entire population has shifted to an aggregate higher BMI, right? The entire population has shifted that way. And that gives you a very different way of thinking about BMI, gives you a very different way of thinking about what might one do about BMI. Just to give one example, sorry, I didn't move forward. Give one example. If you're only interested, say, in the people who meet threshold for obesity, you might say, well, the way to do that is by doing weight loss programs. But if you recognize there's a shift in population, maybe you say the way to do it is to make sure that everybody has access to healthier foods. Those are two different interventions, which are determined by whether you focus on just the people who actually meet a certain category versus by understanding the underlying distribution of population distribution of disease. Now, let's apply that to mental health. This is from COVID times. It's from a study that our group finished and published last year, looking at depression after COVID. The blue bar actually is before COVID, and the red bar is during COVID. And what you're seeing is the no symptoms, which is on the left, fewer people with no symptoms, and more people than with mild, moderate, severe symptoms. That is overall about a threefold increase in depression after COVID. We actually have a follow-up study that we've just done, which will be in the sort of publication cycle soon, which shows, here's the bad news, that actually this threefold increase has roughly stayed over the past year, which is quite remarkable to have that kind of increase in depression stay for such a long period of time. But that's a threefold increase. And if you look at the sort of public narrative newspaper articles about this, they all just say one thing and one thing alone: depression has increased by threefold. That's fine, that's true. But fundamentally, what we're seeing is not just depression increased threefold. What we're seeing is this shift in the symptoms of depression. So again, the blue is before COVID, the orange is during COVID. And what I want you to see is there are far fewer people with zero symptoms than there were before. Fewer people with one symptom, fewer people with two symptoms. Then you get 3, 4 symptoms. Then you get more people with more symptoms. So even if you're not meeting the definition of depression, you're actually having more symptoms, which of course, I would encourage us all to think about the public conversation right now. So a lot of public conversation about isolation and languishing and people not feeling good. Well, fundamentally, what people are experiencing are symptoms of depression. You may not meet clinical diagnosis of depression, but meeting symptoms of depression. And for anybody who is in any workplace, you know that those symptoms of depression are having an impact on work, on people's work and people's quality of life, which is why population mental health, I think, is so important, and why this is such a difficult and important time for population mental health. Just to show you another example of this is, I apologize if there's a typo in my slide name, but this looks at people without post-traumatic stress, people with post-traumatic stress. And what you see is number of stressors. You shift, people with PTSS have more number of stressors as the blue bar, blue line versus people without post-traumatic stress. But of course, what you have is more stressors, a lot of stressors, even among people without post-traumatic stress. So point 2 is we have to think about ubiquity. Now let's talk about point 3. ubiquitous causes determine population mental health. Now, again, I'm putting mental in brackets in each of these because while I'm talking here about population mental health in the context of social and economic stressors, I hope everybody sees that the principles I'm talking about actually apply to health broadly, population health broadly. But I do think that I do think that one of the things that I've tried to do in my career, and I'm grateful to Dr. Cohen for being a partner in a lot of this, is to bring population mental health in from the fringes and to say it's part of how we should think about population health broadly. Now, by ubiquity, I often use this metaphor of the goldfish. Dr. Cohen, I mentioned I actually have a newsletter called The Healthiest Goldfish, just because I like this metaphor. The metaphor is very simple, that you can have goldfish in a bowl and the goldfish can exercise, they can eat well, you can get them a goldfish doctor, but unless you change their water, the goldfish are never going to be healthy. And the metaphor simply gets at the fact that to think about populations, you think about the water, which is the ultimately economic, social conditions in the world around us. So why does that matter? Well, let's go back to diet that I showed you before. Well, this is, as I said, if we're dealing with BMI and you only focus on people with a BMI over a certain number, you might say, well, the treatment is just get into diet programs, deal with diet programs, deal with the individual. That, of course, forgets ubiquity. Well, what's ubiquity? What does ubiquity matter in the context of big body mass index? Well, here's what matters. 20 years ago, bagel had 140 calories, and today it has 350 calories. Muffin 20 years ago had 200 calories, today it has 500 calories, and on and on and on. That's ubiquity. Ubiquity means that there are circumstances in the world around us that change the water, that change our health. And of course, in the context of COVID, in the context of the COVID moment that we're living through, it means that it's the underlying social and economic stressors that are shaping everything about population mental health at this moment. There's another example of ubiquity, just sticking with BMI, which is, well, is there healthy food available? This is a map of New York City, where I've spent many years, which is the proportion of unhealthy food outlets. And you see the darker color is more unhealthy food outlets, which are concentrated in areas of New York that are more economically distressed, meaning in the Bronx, Northern Manhattan, and Central Brooklyn. That is ubiquity. And that's what fundamentally is driving for example, the obesity epidemic, or things like poor schooling, again, same neighborhoods, which results in poor health education. Now let's talk about the moment. Let's talk about economic stressors. This is from a study that we had done, or many other studies like it, looking at economic indicators on the x-axis, and on the y-axis you have suicide deaths. You show the better the economy, the lower the suicide deaths, which is, in a moment like this, one worries tremendously about economic function, how that will affect self-harm and death by suicide in the medium term, because we do know economic function is linked to death by suicide over time. And one also needs to think about, in the context of ubiquity, how these ubiquitous forces are being applied. This is a change in employment by income group in this country. And what is, I feel like, poorly understood is that, yes, there's been a tremendous change in employment, and the change in employment has almost all fallen on the poorest half of the population. In this case, the bottom 25% was illustrated here versus the wealthiest 25%. The employment for the wealthiest 25%, while it had a dip at the beginning, went back to baseline by July of 2020. The employment for the bottom 25%, it remains about 20% lower than it was before COVID hit. COVID has been the perfect illustration of a set of economic consequences and stressors that are disadvantaging groups that are already disadvantaged. And if you think about these forces as ubiquitous forces, we are concentrating the negative ubiquitous forces in the groups that were already under duress and under stress, which means, if you think about the goldfish bowl again, to use about that metaphor, it's like we have cleaned the water, we've fixed employment for those who are affected in the wealthiest 25% in that goldfish bowl. But in fact, we have not changed the water, and the water remains really troubling as a ubiquitous force for those in the bottom 25%. And just to illustrate that, let me go back to the picture I showed you about the study that we did about depression. This is the exact same picture. Remember, I said depression threefold increase, but it wasn't an even threefold increase. In fact, when we divide the group into 4 groups, just focus on the extremes, just because it's easier. Focus on the group on the left and the group on the right. The group on the left is group people with high assets and low stressors. The group on the right, people with low assets and high stressors. Well, what does that mean? High assets means you have wealth, you have your own home, you have some savings. Low stressors, you're not worried about where your kids are going to school, you're not worried about your parents, you're not worried about losing your job. The converse, low assets and high stressors, recognizing, of course, these things are reciprocal constructs. Low assets, you don't have savings, unstably housed, your kids are not in school, you're worried about your job, you're worried about your parents, etc. There's a fourfold difference in likelihood of depression during COVID between the two groups. So yes, there is a threefold increase in population depression at this moment in time, but there's a fourfold difference between the group with stressors and the group without, which is really quite extraordinary. So what we're doing in the context of COVID is we're concentrating these disadvantages in populations who already had disadvantage. And that really follows this notion that we're of ubiquitous forces, and these ubiquitous forces that are shaping population mental health in particular groups. That's point 3. Point 4. I want to make the case about we cannot forget about co-occurring causes. And this is a mistake that we make all the time. We make this mistake in health in general, but make this mistake in population mental health all the time. So let me, I want to start with asking you a question. How much is our risk of depression determined by our genes? So let me set the ground rules for this, because this is a bit of a, this is the kind of thing that would work better in person. I wish we were in person, because I would actually ask you to write this down. But I will challenge you all to actually make a note of your answer to this. Here's the assumption. The assumption is as follows. There are two things that matter, genes and our environment. Those two things both matter for our risk of depression. Accepting that they both matter, accepting that genes and environment both matter, I'd like everybody to answer this question for themselves. How much is the risk of depression determined by our genes as a percent from 0 to 100? Accepting that genes and environment both matter, what percent of our risk is due to our genes? And I would like everybody to be honest with themselves and write down an answer to this question. Accepting that genes and environment both matter, what percent is determined by our genes? I'm pausing for a second. Okay, so now everybody having written down that answer, let us do the math. We'll show you the evidence and say, what's the risk of depression? How much of it is driven by genes? Accepting that genes and environment both matter. So I'm going to show you the math. I'm going to show you this with a bit of a graphical illustration. This is a population. I'm using the same schema as used before, great people in population. And in this population, I'm going to create the people with the gene for depression, single gene. Obviously, there's no single gene for depression. I'll get to that in a second. But the notional gene for depression, I'm marking that as the figures become black or darker gray. And the environment that creates depression, I'm marking as green. So remember, I mentioned that the genes and environment both matter. And when we create depression, depression is red. That's my schema. So the black, which is the gene, and the green, which is the environment, together combine to create red. And there's going to be some few red people without either gene or depression, gene or environment, just because the world is complicated. So let me start with a scenario like this. Here's a scenario where the environment is almost all depressogenic, right? Like this. Perhaps it's the moment in time. Deep economic social stressors like we're experiencing right now. The environment is all green. Remember, the green environment creates depression. There are some red people already because, as I said, the world is complex. But now let me take the genes and show you where the genes are. Remember, those are the black figures I had before. I've made them dots just so you can see it through the green. So the black dots are where the genes are. So the black is the gene. The green is the environment. And remember, I said the gene plus the environment creates depression. So the black plus the green become depression. So now let's do the math. What percent of the depression here is due to the gene? Well, notice every single person who had the gene became depressed, right? I'm gonna go back, see all the black genes? They all became red depression. Well, when you do the math, just focusing on the part, which is population attributable risk proportion, it's 1. Because 100% of people with the gene became depressed. Now let's take a second scenario. Same gene pattern, you see the same black figure pattern, different environment patterns, different green figure pattern. Notice that only two of the genes now are superimposed with the green. Those two become red. So what's the population risk proportion now? Well, now it's only about 40%. So I did not change the gene pattern at all, but I changed the environment. So the answer to my question, which is in a world where genes and environment both matter, what percent of my risk of depression is due to the genes is, the answer to the question is, I cannot answer that question unless you tell me about the environment. Now, I will let everybody sort of look at their own answer and see how many of you actually gave that answer. Maybe everybody got that answer. Maybe it's all correct. Generally speaking, I find audiences focus in on a percentage, even though I told you that environment and genes both matter. Even though I mentioned that, I was very explicit about that. We have a tendency to, we almost can't help ourselves, but come up with a % answer, trying to isolate the cause and say, yes, I know that genes and environment will matter, but here's what I think, here's how much I think the gene matter. And what this little exercise shows is there actually is no way of knowing what the gene matters by itself, because they both matter together. With the plausible assumption of co-occurring causes, you're going to have different estimates depending on other factors that distinguish between samples. Now, does this matter? Absolutely. This matters in many ways. For example, this is from a review about 10 years ago, looking at the serotonin transporter gene, most common genes associated with stressors and risk of depression. Looking at meta-analysis really showing that the results from the effect of the serotonin transporter gene was all over the place. Why is that? Well, fundamentally, because of different samples with different environmental factors. That the environment was just totally different for all of them, which makes our genotype-phenotype association estimate really difficult to come by. You know, this is from a compendium slide with, thanks to Dr. Cohen for this, with multiple studies looking at different large GWASs, looking at understanding the architecture of depression. And this is from a commentary of some of these GWASs, which says genetic variants selected by GWAS typically explain only a fraction of total family or twin-based heritability. Why? Well, because it's only a fraction because the much larger fraction is ultimately determined by the forces in the world around us, which means that we simply cannot ignore the environment within which population live, within which mental health happens, which means you cannot ignore the principles of population mental health. It doesn't matter how much of a deep dive we do into genetics by itself. By itself, it's never going to be able to answer the question how much of our risk of depression depends on our genes, because how much of risk of depression depends on our genes depends on the context within which those genes operate and become phenotype. When you have contexts that are as different as this is New York Times Square in 2019 versus 2020. When the context of the world around us has changed so much, our phenotypic expression of depression or of any element of mental health is so determined by the context that focusing only on the genes is ultimately foolish. And the fifth point, the last point, and then I start winding down so I don't get questions, is to center health equity, centrality of health equity to any population health or population mental health discussion. And there are many different ways of talking about health equity. And I just want to show one simple illustration here, which is, this is just a schematic illustration. Looking at, we always have to remember that health equity is a complicated, in a complicated balance with overall health. So this is, the top bar says, suppose you have no intervention, that you have a situation where you have two groups. One group has a DALY disability, just like there's a 50, the other one has DALY of 25, any measure of health. You can say more depression, less depression, it doesn't matter. If we add health, in this case, we're adding DALYs to the population by adding 1 unit for every 50. Well, you've now taken the 50 to 51 and the 25 to 25.5. So you've increased overall health, but you've also increased inequality. Same if you add 10 for every 50, the 50 becomes 60 and the 25 becomes 30. You now have an equality of 30. So you've increased overall population health at the expense of equality. And I think it's really important that we keep close to our mind, what are the principles that matter? What are the principles for us that matter? And we've seen this dramatically in the context of COVID, of course, in the context of vaccines, anybody's interested in this concept, I did a piece in JAMA a few weeks ago called The Price of Health Equity, where I tried to get into this to explain that health equity should be at the core of what we do in population health and population mental health. And it is, and we need to make sure that we structure our thinking and our conversation about that. You know, and to think of it another way, you can have perfect health equity, which we could sacrifice for health inequity. And again, this is exactly the example of the COVID vaccine, that we can improve health and improve and create wide inequities. And that should be broadly unacceptable to us in health. Of course, the world conspires against us that way because the world is moving more and more towards health inequitable conditions. This looks at physical health angina, heart attack. And I want to show you the difference between the richest 20% of the population, which is here in the blue, and the poorest 80% of the population, which is here in the orange. And what you see is, you see this divergence of these lines over the past 20 years. We have created a world which is more and more health inequitable, not less, more health inequitable over the past 20 years, which of course is the moment that COVID hit, and we can talk more about that in another sort of COVID presentation. And tying this into the mental health now, this is from a study that we've been involved in with Hong Kong, where Hong Kong has actually been living through not just the COVID stressors, but also social stressors in the context of civil unrest around political moves there, as people have read. And this looks at the same assets, high assets, and low and high stressors, low assets, low stressors that I showed you before, which is the bar on the left is people, and this probability of depression is high unrest, high stressors, and the bar on the right is low unrest, low stressors. But all I want to see is that the stratification by assets, that people with high assets at every level have lower depression than people with low assets. That fundamentally, if we actually want to center equity, we need to make sure that our focus remains on people with low assets who are always at greater risk of poor health and poor mental health in any circumstance. This is from a study in the UK showing the exact same thing, that the more income you have, the less likely you are to have anxiety in the context of post-COVID. So let me wrap up. Because I want to keep this under 40 minutes and talk about the implications of population mental health approach, because I actually think that this approach has real implications. If we think of the world that some people are exposed and unexposed, exposed to sort of to the kind of stressors and traumas that actually create worse health. We recognize everybody's exposed to some extent, but if we just focus on people who are exposed, let's say the red are more exposed, we know that there's going to be poor mental health, and the excess are poor mental health among the reds, but also among the blue, among people who are unexposed, right? Everybody now understands that, but the density of the excess is higher among the reds than among the blue. But if we focus only on the red, it actually has real implications. So this is the risk factor and the prevalence. If we focus only on the cutoff, on the people who are at high risk, and we say, let's just deal with the people with a lot of stress, just deal with them only. Well, we're just dealing with this. We're dealing with the red people, and we're forgetting all the blues also have excess. A population health approach and a population mental health approach takes the whole risk factor and says that we need to shift the entire population risk. That now takes the whole population like this and reduces the number of people who are exposed. And that fundamentally is a population mental health approach. That means that in the context of COVID, in the context of a large economic social stressor, a investment in infrastructure, an investment in improving the social safety net, an investment in making sure that people are not unemployed or don't have the resources to see into unemployment is an investment in population health generally, and population mental health specifically. And population mental health is much more sensitive to changing social and economic contexts than are other forms of health, which means that we who are interested in population mental health should be at the forefront of making it clear that political and policy moves to invest in infrastructure, in the economy, in assistance in housing, in, for example, lifting things like a foreclosure moratoria, like maintaining things like foreclosure moratoria, that should be very much within the bailiwick of what needs to be done to improve population mental health. Thank you for having me. I will stop there. I want to keep to 40 minutes, which I think I did. We have time for questions. It's a privilege to be here with you.
Great. Thank you so much, Sandro. That was terrific. And so, folks, I encourage you to put questions in the Q&A. I'll start with some that I have. You mentioned in the beginning of your talk multiple generations, and I wanted to see how, and I know you've done some cross-generational work, and so how you see some of this, if you want to comment on the intergenerational transmission and how some of these, I rarely see that from discussed from a population lens.
Yeah, thanks for bringing that up. If anybody's interested, I think the best empiric evidence sort of for intergenerational transmission has been done by Dr. Conan and her own team. But let me just talk about it sort of at a conceptual level. I don't think one can think about large-scale population phenomena without recognizing that they're not just, they don't just start over with every life. Like population phenomena that affect me don't start the day I'm born. They actually precede me. And just to talk about some of the forces I talked about right now, which is, for example, assets. And if I were doing a more general health talk in the context of COVID, I would talk more about this. But let me just bring it in since you asked. The maldistribution of assets by socioeconomic and racial groups in this country has its roots in centuries of disenfranchisement of particular groups. The slavery that characterized the disenfranchisement of Black Americans or from then on, which ended in the 1860s, then became Jim Crow laws, then became housing segregation, then became redlining, then became poor accumulation of wealth, then became this generation where Black families have about 1/10 of the resources of the wealth resources of white families. Then comes COVID, which means that now Black families are more likely to face the economic stressors of the moment. And that is directly traced to the historical policy decisions that ultimately become intergenerational health. Now, there are multiple pathways to intergenerational health. Gareth and I have done some work together on sort of epigenetic pathways, which I think are really important way of actually understanding how some of this gets under the skin. But fundamentally, there are these resource allocation decisions that influence exposures that ultimately become health. So I don't think there can be population health thinking of any kind that is ahistorical. Fundamentally, all of this is historically based and intergenerationally based.
Thank you. Yeah, that's really interesting to think more about. So some questions. Dr. Valentina Lemmy from London School of Economics and Political Science, said, thank you. And can you give some examples of successful and less successful policies to improve population mental health? And along the same lines, there was another question of, is there evidence of the effectiveness of universal basic income trials for reducing economic inequities and promoting population mental health?
Yeah, so the good news, I'll start with the good news and bad news. The good news is I think this is a really interesting area for any student who is interested in a career over the next 20 to 40 years, because the bad news is that our evidence for this is terrible. And universal basic income is a good example. I've been very careful, for example, to comment about universal basic income because I'm not aware of any evidence that actually that shows universal basic income and its ultimate effect on health. I think conceptually that is probably a good idea, but I actually don't think that there's been any rigorous studies that have actually demonstrated. In some small studies, there was a big study happening in Ontario, Canada, which then was suspended when there was a change in government. So we actually have very limited evidence for this. And so I actually think that the moment in time lends itself really well to large-scale economic and social experiments that follow population mental health. The challenge, of course, has been that it requires large-scale data collection that happens before and then proceeds during and after the event. Historically, that has been prohibitively expensive. I'm sort of more optimistic that we'll be able to do more of that now as digital technologies to collect data on mental health become more widely used, recognizing the limitations of that. And we're sort of in the throes right now, I think, in the field of criticizing what we get from those methods. My general feeling is we always go through this whenever we have new methods, and then we get over it, and that's a good thing. And because I actually do think that some of the tools we have for collecting large-scale population mental health data now will allow us to answer some of these questions. So I'm actually not aware of robust, rigorous experiments in the way that I think one might wish from an economics vantage point that show us how social large-scale economic intervention inflect population mental health, but I would love to see.
Along those lines, one of the things I've still noticed when people do these sort of national or these innovative ways of surveying people is the absence of mental health data. Just some things I've reviewed over COVID for different policy briefs and things I consistently being the one who's commenting on, well, you could actually also be assessing mental health along with food insecurity and things like that. And so I wondered if you could comment on, have you seen a shift where there's a broader recognition of the importance of mental health data, and where do we still have work to do on communicating that? Because I feel like there still is a gap sometimes. And I apologize, folks, there's a construction going on.
I actually thought I thought there was an important moment in the last presidential debate when President Trump brought up mental health in the context of what's going on in COVID. And leaving aside the challenges with President Trump's leadership in context of COVID, which is acknowledging just so that nobody thinks I'm actually blind to that. I just want to be clear. But I actually think the fact that a president who arguably was sort of using the moment for his own purposes, but brought up mental health without thinking twice about it, I thought it was a really important moment, because it actually said, I mean, mental health has been a taboo in national politics, right? It's like, but it was actually brought up fairly casually as in something that we accept. So I actually thought that was a really important shift. What I really would like to see is in the presidential debates or presidential primaries, there are discussions about, well, if we do X, how is it going to affect population mental health? That's, I think, how we know that some of these things have penetrated. So I actually am optimistic. I think we see a lot more conversation, you know, in the context of COVID. It's been such a terrible year. Nothing redeems such a terrible year. But if we're trying to extract good from bad, one of the things that we should extract from it is a greater recognition of some of these forces, and some of these forces that create poor mental health, and a greater recognition for mental health. And I actually do think it's happening. I think those of us in mental health, and particularly in population mental health, perhaps, you know, I think we have a long-earned underdog mentality about this, because like, well, nobody pays attention to us ever. And yeah, I think we've earned that mentality, but I do think that things are shifting, and that there is much more openness to the idea of population mental health.
Thank you. I like the optimistic view. It is true. There is much more just popular conversation again about that's persisted throughout COVID. So that is actually, I also think that's really promising. Another question can you speak to examples of policies that improve population mental health that are cross-sector partnerships between hospitals and healthcare systems or other sectors like school and housing? Any thoughts on that?
Yeah, I think it's a great question. I actually think that almost by definition, effective population mental health approaches would need to be approaches that are cross-sector, that deal with housing. There are a number of sort of smaller scale examples that have been done, that have been validated. Robert Wood Johnson Foundation has funded a number of these. There is a compilation of them in the National Academy's report that compiled a number of these examples, and they are typically, and I think that report was 2017, and they are typically sort of cross-sectoral examples that engage communities and schools done in relatively smaller scales, showing that when you invest in more robust structures of living for people, and when you alleviate the stressors, essentially showing what you would expect, that people's mental health gets better. And what I want to see, which I don't think we have yet, is that that also demonstrates the return on investment in our efforts, in our social and economic investment, because it stands to reason, to my mind, that that will become economic yield. Not only will it become health yield, the health yield will become economic yield. And that is really, I think, ultimately what we need to convince, right, to make the argument that this is worth the policy investment.
Yeah, thank you. I wanted to make sure I give you a chance to also, and I know you didn't ask me to do this, but to talk about your new book, Contagion. And before I ask another question, Contagion Next Time, which I know is coming out. I know it's pre-order on Amazon, but it's coming out in November, I think. And
thank you. Thank you. So very briefly, the I have this book called The Contagion Next Time, which is an homage to James Baldwin's Fire Next Time, which is it was a book about racism. And the book is not about racism, but what the book is about is fundamentally, it's about really what I talked about here, is that we cannot understand the consequences of this pandemic without understanding the underlying social and economic factors, including racism, that shape the world around us. And the reason I want to write this book is because what's going to happen in the fall is there's going to be a flood of pandemic books. I'm aware of that. And they're all going to say correctly that we need to be worried about biosurveillance, we need to have better data, we need to keep viruses from crossing over, zoonotic viruses from crossing over the human species, we need to create better stockpiles and all that. All of that is important. But to my mind, the consequences of COVID were such that they were so socially and economically patterned that unless we deal with these underlying social and economic structures, the next pandemic will come. And if it eludes all these various sort of high-tech biomedical approaches, it's still going to have the same negative consequences on the health of population and the mental health of populations as we're seeing now. Because fundamentally, those are a function of the fact that we have large parts of the population, the poorest 80% of the population, that doesn't have the flexibility to work remotely, that has unnecessary morbidity and preventable morbidity because of the life course factors, because of the multi-level factors, that both of which result in greater exposure to COVID and in greater exposure to severe COVID when you get COVID. So the premise of that book is to say that we can do all the sort of the fancy biology that we need to do, and that's all good. But I don't want to lose the message that what this moment should have taught us is that we need to invest in actually mending these underlying social and economic deficits that create a population that has that's characterized by two factors: greater risk of getting a disease than necessary, and when it gets the disease, greater likelihood of having severe disease because of underlying poor health. Those two are fixable, and those two have nothing to do with what we think of traditional ways to mitigate pandemic spread. They have everything to do with our underlying social and economic forces.
Thank you. And that gets at a question that I've been thinking about, that back when I was at Columbia in training, Bruce Link used to talk about how that given how common mental disorders are, that if everyone who had a mental disorder was going to go to individual treatment, there's just not the capacity in the system to provide that the individual therapy for everyone with a mental disorder. It just isn't, like, it's just not sort of, in any system, right? So then what is, in terms of population mental health, or thinking about it that way, what would you say are the top levers, and are they different from physical health, or is it really sort of all the same thing? And partly I ask because I think one of the positives out of COVID has been, insurance covers virtual therapy. There have been some on the access and provider side, there have been some positives, but that still leaves these huge gaps that most people don't have access to mental health care and don't have insurance, and don't get treatment. So what are the other levers that can be operated?
Yeah, I actually think that a lot of the levers are the same. I actually think in my talk, I talk about population health and population mental health. And in part, I do that intentionally because I as you and I have spoken in the past, I think we'll have real progress, and this will be after your and my careers are over, where mental health, physical health divide will no longer be there. Like fundamentally, right? If we think about it, it is a function of historical evolution of the fields where mental health and physical health have been separate. But fundamentally, these are expressions, they're phenotypic expressions of different organ systems in the body. And the levers, the economic levers and the social levers are the same that improve physical health and mental health, with the rare exception, and the really rare exception, of heavily genetically determined disease, things like sort of pancreatic cancer. These are rare exceptions. Everything I said applies equally well to mental health, physical health. Now, the one particularity about mental health, though, is that mental health is more proximally sensitive to social and economic stressors than is physical health. And this largely because of induction periods. So we're dealing with things like cancer and heart disease. Like, in order to get heart disease, you need to have accumulation of atherosclerosis. Atherosclerosis is socially patterned based on the food you eat and based on social stressors, but that takes decades. But mental health changes in a rapid period of time. I mean, that's why we're seeing threefold increase in depression in time of COVID. We're not seeing threefold increase in cardiac disease yet. We will see increase in cardiac disease because we know that more depression is associated with more risk of cardiac disease, but it takes longer. So I do think it's the same levers and the same forces, but mental health manifests sooner, which I think puts those of us who are interested in care about population mental health sort of at the front lines, and that mental health is sort of like the canary in the coal mine that predicates how health is going to come after.
And I'd also you see the impact of mental health much earlier in life. So people start manifesting in childhood, adolescent, young adulthood is often the onset for many mental health problems before people can be physically healthy. And so there's also that sort of earlier manifestation as well. So before we end, I guess I'm sure there's a lot of students and trainees in epidemiology and in population health on this, or who'll be listening to this. What advice do you give to the next generation in terms of who might be interested in research or other work, applied work in population mental health, or even broadly population health sciences? Yeah.
Number one is I think it's a really I think it's a really fruitful area. I think it's an area of where there's a lot of interesting questions. I think there's some challenges with funding in the area for sort of structural reasons in terms of the funders that fund mental health. But I think there's some really important, interesting questions. I think there's plenty of space for people to make important contributions. I think in a more particular, my general advice to trainees is if they can find a way to work with Dr. Cohen, an excellent mentor.
Oh no. Okay, thanks, Sandro.
You're welcome.
Great. Excellent. So before we close, anything else you want to make sure? Any points?
No, I'm delighted that I'm actually delighted that you're having this this series, and it's you know, I saw one of the comments, one of the Q&A, somebody said, well,
yeah,
for politics to really advance, we shouldn't just mention mental health, we should mention mental health in the context of economic causes of mental health. And I couldn't agree more. That's exactly how we want to advance the conversation. And I sort of feel like, you know, when I'm invited to give talks like this, I'm always honored, and I try to accept, because I actually think the more we have this conversation, the better, right? Like the more we have this conversation, the better. And that, you know, the fact that, Kerstin, you said there are students in attendance fills me with hope, because students are the ones who are going to be doing this work for the next 20 years, which are going to advance things. And, you know, sometimes I think it's very frustrating within the academic world. Same thing, it's taking so long to change, but it takes decades for things to change. And that's sort of okay. And so I actually feel like, you know, again, in extracting hope from a very dark moment, if we emerge from this moment with population mental health being more of a concern for academics and for policymakers, that is a positive in the long term.
That is excellent. Yeah, and a positive that will impact future generations as well, as you mentioned. So that's terrific. Well, thank you, Sandro, so much for being here today. And thank you for everyone who joined us. We will have a captioned video of this on our website and on the Harvard Chan YouTube channel. So I put the website in the chat, and join us on our next one is on May 19th, and we'll be sending around information about that. That's a memorial lecture for Jane Murphy, who was actually a psychiatric epidemiologist who did some of the you know, foundational work on the relationship between social factors and mental health. So thank you, Sandro, and thanks everyone for joining us. Take care, everybody. Bye.